Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. This is a part 2 episode where we are speaking with the leaders of the Connected Health Initiative. We have Brian Scarpelli, Executive Director. Brian, welcome back to the program.
Thanks so much for having me back.
And Caleb Williamson, he is responsible for the State Public Policy Council at the Connected Health Initiative. Caleb, welcome back to the program.
Glad to be back.
Awesome. So this is a very special, episode because it's our 100th episode of the Virtual Shift. Policy is very, very key to where this industry is going, and sometimes innovation is inhibited because of either the lack of policy or too narrow of a policy relative to allowing things to flow. So your organization is a natural organization to speak to relative to how do we innovate and how do we transform the market. So there's a lot going on the policy front, as you know. So let's jump in on those points. So just minimally, there's a lot going on in the context of a lot of the public health emergency extensions expire at the end of the year, right? And so can you tell us a little bit more about what's going on that particular front? We'll start with you, Brian.
Sure, absolutely. It's a critical and really timely angle that you raise. I mean, the way I see it, there's a great many laws, regulations that exist that were put in place in good faith, some 30 years ago. And most of them are themed in checking fraud and overuse. That's sort of the motivation. As technology has evolved over time, and we're seeing more and more the potential for digital health tools, even modest use cases, to really transform and drastically reduce costs across a range of the most expensive use cases, but a wide range of them. You know, it does beg a public policy debate. I think an overdue debate about, are those restrictions serving the public interest anymore? And there's some that I would argue very clearly do not, because they were basically put in place in a pre-internet era.
Yeah, I was just going to say, 30 years ago, we didn't have wireless data.
Right.
It was in its infancy. And 30 years ago, we didn't have the internet as much as we do now, for sure. So that opens up, that's where innovation comes from. That's why we're
Absolutely.
not, we need to find ways in where policy can embrace innovation versus stifle it.
Absolutely. And I can give you probably this might be the example that more people have heard of than not. A great example of this that probably would connect with a lot of people is with respect to what Medicare calls telehealth services, which is under the law, to make a really long and boring story short, is a live voice video call only, not the idea of a device that captures some reading from your body, like remote monitoring, stores it briefly, then transmits it at some interval. That's not considered in scope for Medicare telehealth services. But when Medicare telehealth services were defined in law in the early 90s in the Social Security Act, and we think about what was the internet in the early 90s, right? So drastically different from today. But the thinking of the policymakers who crafted that law was that people would get in their car and drive to a telehealth center, which would have kiosks. And then you would go and have an appointment and sit in front of the screen at a kiosk, and then get in your car and drive home. And that beat having to drive all the way to the city to go to see your doctor. So in order to check fraud and abuse in that lens, they excluded the ability for any Medicare beneficiary who lives in an urban or suburban area from even receiving the services. And even for those in a rural area, you had to be in a healthcare professional shortage area. So it's even more restricted. And the home was prohibited from being where you receive your care. the
Yeah.
originating site. That's still in place today. What brings this to the PHE, as like you raised, which is super important, is that once a public health emergency was declared, it gave them new authority to do a whole bunch of things, including set aside a whole bunch of these legacy restrictions. And they did that. The public health emergency did eventually expire, we all know.
Right.
And what's happened is piecemeal, Congress is addressing either making permanent or, extending some of these setting aside of these legacy restrictions, 25 plus years old.
So let me go to Caleb. Do we run policy based on fear? And I asked that question in the following context. This idea of fraud and abuse seems to be the barrier that you have to breach in order for something to be viable. And if you look at fraud and abuse in the current system, I'm not saying that fraud and abuse won't occur in a new system, and we always have to put safeguards in place to protect ourselves, right? Because we want our dollars, limited dollars, to go to the purpose in which they're intended. But it just seems like this is a kind of a canned answer for the inability to act on the embrace of innovation. What are your thoughts on that?
Oh, I've got some hot takes. But I would say that fear in the policy space seems to be born out of, for lack of a better term, ego, and not willing to admit that there is a learning curve or there's a gap. I have noticed this more when I've had conversations with legislators, specifically talking about technology and just technology before we even talk about the intersection with technology and healthcare. And the first thing that they bring up is, oh yeah, we got to really regulate it because the hackers are very active. And I said, wow. I said, that's a great point. Good point that you brought up. Can you identify any positive use cases with me? We would go about 5 minutes on a call before they're like, I don't think there are any positive use cases. And I said, okay, well, let's think about what technology has really brought us. Your phone is now your bank. Your phone is now access to your local healthcare provider. Your phone is access to research if you can't make it to your healthcare provider. Those are micro positive use cases of technology. And when we create very simple examples of what that looks like, you start seeing the fear go away. You start seeing legislators, perk up in their seats. They start talking more about, okay, so it's not all bad. How do we make sure that we promote what's good? I share that to reiterate that the fear associated with technology, the fear mongering that we see with policy statements and positions taken by elected leaders at the state, local, federal agency levels, it is rooted in this unknown. I can only imagine. I'm fortunate enough to grow up with technology in my hand.
Yeah.
And so when you're working with legislators who are transitioning into the legal definition of a senior citizen, this is something that is completely foreign.
There's so many different ways of looking at this, right? We hear folks, the new buzzword is health equity. I am an advocate of looking to achieve health equity, but I think it's their words, and here's the reason why. If health equity is about providing everyone equal access to care at the same price, would you agree that that's kind of a brief definition of equity?
I think there's something there, yeah.
So if that is ultimately the goal, let's make sure everybody has equal access to care at a reasonable price. We would not have Medicaid working against the policies that Congress has in terms of healthcare. We wouldn't have health insurance programs that have an HMO, a PPO. We wouldn't have Medicare Advantage versus Medicare because they all create different gates to healthcare. Narrow network, broad networks, co-pays, co-insurance, right? These are all barriers to care. And for the folks of the greatest need, co-pays actually, in my opinion, is the greatest barrier to care. Because while we can all clap and say everybody's got health care, not that that's true, but we can clap and say that, but I can't access care because I can't afford this copay. And yeah, providers can go and they can make their best effort to collect that copay, and therefore the pattern becomes the ability to ignore it. The copay from the consumer perspective is the barrier in and of itself. They don't know the healthcare system and how to work it, if you will. And maybe by eliminating maybe copays and at the end of the day create greater equity for everybody.
Yeah, I agree with you. I think that's sadly an under-recognized barrier is copays, because it really is a pain point. You think about the whole value chain, of how technology is developed and the hoops that one goes through, for example, to get through an FDA approval and then bringing it to market, and all the way down to that provider actually interacting with a patient and utilizing it, and each of the sort of pain points there. I do think copays rise to the top there. That's why, to circle back a little bit to the public health emergency, a topic that we were discussing a minute ago, one of the first restrictions on remote monitoring, asynchronous remote monitoring and telehealth, was set aside under emergency authority by HHS was to waive copays.
Yeah, that was a smart move, and that I would say was the greatest healthcare reform act that they employed in order to ensure patients got access to care. Now, as you said, they eliminated it, right? So now so now we see people dropping off the program, and therefore it's kind of the proof point of no copay, people coming in, they love the program, they love that patient engagement. You saw greater compliance in medication and people being more engaged in their ability to establish a greater state of wellness. And then now we have this experiment, I'll call it, of all right, we took the copays clause out, now you have to pay. And then we saw this opposite effect. People started dropping off. People don't even join the program because they just can't afford the copay. I hear it every day.
Yeah, absolutely. It really does get at the heart of the infrastructure that would facilitate this care. And I think about, other angles to this same theme, providing connectivity to unserved and underserved communities, which is, there's a large grant program that's currently underway being administered by states and territories, $48 billion, believe it or not, that is only just starting, that we've been pushing the states and territories to prioritize healthcare, digital literacy, and to ensure that the networks that they're funding and maintaining are robust enough to support a healthcare use case. But digital literacy is another angle. I think that lots more work could be done, and I think the issue, I almost feel like a core problem here that underlies all this stuff, or maybe that's preventing, is that I think that there is as strong an evidence base as you could want that shows that the responsible use of digital health tools, whether it's just a live voice video call, remote monitoring, even periodic just voice only check-in calls and app-based services and notifications, et cetera, improve patient engagement in their own health, help their understanding, help them be proactive, catch things early. Prevention is something that is, except for the diabetes use case, and in my personal opinion, it's done poorly by the Medicare system. Prevention is something that is not at all prioritized in the Medicare system today. It's all about treatment and like butts in the seats kind of mentality, fee for service, rather than actually accomplishing this transition to value-based care.
I agree.
Underlying it, I think is that there's probably a dynamic that exists in many other industries, in that the way things are today, there's a large, in this case, like you could think of a pie chart or a pool of resources, money that's allocated. And if you start changing the slices of the pie, then people start getting upset, and creating friction to the transition. So that, and
that's the key, right? You're talking about lobbying and who gets harmed in this transition. Caleb, let me ask you a question. We have a health system, and again, I don't want to beat the dead horse here, but let's use the copay as the example. Maybe we turn that into a negative into a positive. Maybe we're putting our incentive dollars too much on one side of the equation and not enough on the consumer side of the equation. The point there being is value-based care is all, consumers don't even know what value-based care is for the most part. If we gave the consumer the incentive to engage and change health behaviors, lose weight, diet, exercise, medication adherence, do you think that that would change public policy at the state level or federal level?
Yes. When we're thinking about the demographic of people that are politically engaged at the state and local level historically, and those who have strong ties and relationships with their healthcare providers in the healthcare community, I think creating more value and more incentive for the consumer could positively impact the way that legislators at the state and local level are thinking about healthcare policies. One thing I do want to say is that, it's a shame that it took a global pandemic for us to even slightly shift towards a value-based care approach. And again, to the points that we mentioned earlier about the copays, those are truly barriers not only to entry, but barriers to remain actively engaged within the healthcare community.
Yeah.
And so I do think that creating more incentives for consumers, and of course, I have to say this, getting more consumers politically engaged at the state and local level definitely could have some positive impacts.
So, Caleb, I'm going to come back to you, and then Brian, I'm going to ask you to close out here. What do we see at the state and federal level in the next 6 to 12 months on policy? What do we see as far as policy changes that might be coming? I know we're running up again an election year, but nonetheless, what do we see lawmakers doing?
Yeah, so I can share definitely from the state and local perspective that you will start seeing more task forces convening. You will start seeing, I believe, more cross collaboration between federal and state. I have a favorite restaurant in DC, right? And I was just there with a few elected officials at the state level who were in DC. And, they were just having general conversations. They were like, yeah, we were brought in to talk to some agencies about how we're trying to implement some of these things and how we're talking about artificial intelligence, how we're talking about data privacy, how we're talking about healthcare at the agency level. And I said, wow, you guys came all the way out here just to have that conversation. He said, yeah, it's needed. And so I think that there is a growing need for cross collaboration between the states and feds. And I think we're going to start seeing that. The various task forces that you'll see will probably deal with artificial intelligence. I guess now it's about 26 states that don't have a data privacy law.
Really?
You start seeing some working groups talking about that, but you can't even talk about some of the major issues in the technology space and in the policy space without touching on broadband connectivity, without touching on data privacy, and so these are going to be the task forces. We're going to start seeing it's going to almost be like a pot of everything soup. You're going to start seeing these task forces that are supposed to be geared towards talking about artificial intelligence or data privacy, but in the midst of doing those meetings, they're going to be covering the gamut. They're going to run the gamut with everything that they address.
Interesting. You touched on AI. I can't leave policy discussion without talking a little bit more about AI. To me, it's a growing trend. AI I love it. I'm a technologist, so I love it. I think it has great value in healthcare. I don't know if it's mature enough for healthcare because, Brian, you started out the discussion talking about this is about life and death here. Right. This is about wellness. You got to get it right 100% of the time. And at least that's the objective. Get it right 100% of the time. AI is really about, well, how was it trained? And what's the question that I'm asking? Any thoughts on that, Caleb?
Yeah, I think when we're talking about artificial intelligence and the benefits and potential uses of it in healthcare, I think we definitely have to think about it with the risk-based approach. What is a very low risk versus a high risk use? And I think that, yeah, I think you're right. And I think taking a risk-based approach, I think it will allow folks to identify how will this help us get it right, but how do we make sure that this is not replacing or, the possibilities for hallucinations? How are we going to ensure that this is not going to increase the amount of times we get it wrong? Yeah. And so I do think that there are definitely some things to think about. I think what is important is to have initiatives like ours and other folks get into the fold and start having these conversations in the midst of artificial intelligence, because when this risk-based approach is established, we want to ensure that we're not just thinking about risks from just the provider side, from the payer side, we want a holistic risk-based approach. And I think that is going to be something that can actually help us in the long run.
Yeah, I agree. So, Brian, let's close it out here. Let's first talk about interoperability and data security. The biggest flaw in healthcare today is that EHRs, in and of themselves, something that the federal government funds relative to adoption, and basically makes it mandatory. Otherwise, you get penalized. An EHR today cannot, with 100% accuracy, match patient records because their EMPI is a probabilistic matching algorithm, not a deterministic matching algorithm, right? So that introduces errors into the system. So from a policy perspective, how do we move? One thinks that a deterministic matching algorithm is based on patient identity using biometrics or some other form. How do we see policy changing to improve the use of technology in interoperability and make our QHIN investment that much more robust?
Great question. Well, first, I would just this does kind of tie back to some of the maybe a little bit of a broader question you raised with Kayla a minute ago. Is like, given the fact that there's an election in November, right, and a Congress potentially being lame duck and all that, where would activity be? What you raise here, interop data flows, is certainly an area of guaranteed activity at the agency level. Congressional level, my expectation and hope is that we do see some extension. It should be permanent, but we'll take any extension of the waiver of the telehealth, again, live voice video Medicare telehealth service restrictions on home as originating site and geographic but aside from that, I don't realistically expect Congress to do much of anything further. The reason that I can guarantee you, which is something you probably should never do when it comes to government acting or not acting, but the reason that I can guarantee you that there's going to be some new activity with respect to interoperability is that the component of the Health and Human Services Department, the ONC, Office of the National Coordinator for Health IT, has already completed, in coordination with HHS's Office of the Inspector General, it's been almost, I think at this point, 7 years or something like it. It's kind of an embarrassingly long time, to be frank, but has finally put into place the regulations that Congress told it to develop in defining illegal information blocking and enforcing against illegal information blocking. And they just solidified what the penalties will be. Like that happened, I think, 1 week ago. So that's a big deal. That's in place now, right? So I think what everyone probably who's affected by these regs is thinking about is, all right, how will this be enforced? That first enforcement case that gets made public is going to set a lot of precedent, and no one knows what it will be. Will it be a household name company? Will it not? I think realistically, the agency is probably looking for an extremely flagrant violation that, set an example in addressing. There's since then been two further regulations that ONC has developed that they call HTI 1, and then now there's a new one called HTI 2, which is, what, the acronyms are relevant. Basically, what this reg was doing was making some further updates. For example, added an exception to the illegal information blocking definition, and then introduced some new AI transparency reporting requirements when the AI falls under the definition of certified EHR technology, falls under that jurisdiction. So now there's a new rule that's going to make some further updates to the reg to better enable interoperability. Moving forward with these, I think it's safe to say, because they're surveying the landscape, talking with companies on all different parts of the ecosystem, and identifying where there might be some gaps, flaws, and things like that they need to address in their existing information blocking rule. So that's something definitely for people to look out for.
Close this out relative to the Connected Health Initiative and where you're going. What's the number one thing relative to what your organization is doing?
Yeah, thank you. So I think the areas of the most activity for us, and I expect that to be the case because it's where the most challenges are and the most opportunity, I think, is in AI governance that's both healthcare specific, and there's going to be a lot of that, as well as cross-sectoral. There's AI rules that will affect a healthcare company just like they would affect someone not in the healthcare industry. they're probably, it's not inside baseball to point out. I think most people know there's an executive order that the president signed some time ago that ordered all the federal agencies collectively to do almost 100 things, and a number of them affect health, and some affect health as much as other sectors. So that whole governance structure, that's agencies looking at their existing authority and regs and saying, do we need to make updates for AI? And there's going to be probably an overwhelming amount of activity for a lot of people on that front. If you're affected by it, I would really look out for it. We'll be extremely active there. Reimbursement, modernizing the Medicare reimbursement construct to ensure that some real, I think, that we're trying to get CMS to take the easy wins here. For example, right now, the system treats all software the same. That is, it treats like the Windows operating system in the same way that it treats software as a medical device like clinical decision support that includes AI. It considers it an administrative cost. The agency knows that's not right. How do we modernize the system for that? That's something that will most definitely be working on. And then the last one I would raise is, I can't predict exactly when the activity is going to go forward, but modernizing privacy and cybersecurity regulation. There's an immense amount of congressional activity trying to move things towards a cross-sectoral privacy bill. This version is probably not going to sail through, but I think that conversation will continue. And policymakers are unable at this point to ignore the magnitude and quantity of cybersecurity breaches of healthcare sectors and how it's affecting patients and others. They have to do something. I mean, this is me just parroting what I'm hearing. So that's another area I think that there'll be a lot of action on, if you will. We're going to be quite active on.
We have to end it there. Brian Scarpelli, Executive Director of the Connected Health Initiative, and Caleb Williamson, who leads the State Public Policy Council for the same organization. Thank you for participating in this two-part series. It's been very educational. Forward to having you on the program again in the near future.
Many thanks. Great to be here. Awesome to chat with you about all these things. Very exciting.
That's today's shift. I appreciate the audience taking the time to tune in. If you missed part of today's episode, you can tune back in at the healthcarenowradio.com at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. And be sure to check out the program page at thevirtualshift.co. As well, remember to follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.